I'm the Division Chief of Comprehensive Ophthalmology here at UCI, and I thought this talk was very relevant to a lot of patients that I see. It's very what I see day to day. It's what a lot of patients ask me, so I thought it would apply to the general population, and hopefully it's helpful to you guys. So my talk is about my vision is changing with age. What symptoms are important to check? So topics that I'm going to cover today are things that I think everyone doesn't necessarily get as we get older, but they're definitely three diseases or processes that happen as the eye gets older. And those three would be macular degeneration, glaucoma, and cataract. So just in general, talking about vision loss in the elderly. 1 out of 3 patients have some vision loss by about age 65. And that doesn't necessarily mean the patients are going blind, but they're noticing they don't have as crisp, as sharp, as good vision as they used to maybe 20 years ago. And as we get older, that affects a lot of things, basic daily activities. Some patients tell me they can't go to the grocery store because they can't see. In general, they can't read labels, they can't see distance. So they start to isolate themselves, and sometimes patients can become depressed. Obviously, if you can't see that well, going downstairs or on sidewalks, even walking down a straight path, there's more falls. So it becomes very disabling because people have to rely on others, and you get loss of independent living, which I think is important to all of us at all ages. So in general, at 80 years of old, what are your chances of having these disease processes? So cataract, I always tell people, cataracts aren't a disease. It's just a normal aging process of the eye. A lot of patients ask, what can I do to prevent getting a cataract? As of this time, there is nothing you can do to prevent it. If you can cure the aging process, then you can cure the cataract. But cataract is a normal process in the eye that happens to everybody. Macular degeneration is an actual disease process, and they say about 35% chance of getting it at 80 years old. Glaucoma, your chance is about 8%. So vision impairment, things that we can prevent, unoperated cataract. These days, we're able to catch a cataract soon, earlier on, and we follow it slowly. And so for someone to get blind or lose vision from a cataract these days is very, very rare. We would probably see that more commonly in third world countries or people that don't have access to medical care as routinely. Glaucoma, also, there's so much new advances in glaucoma, so much more treatment earlier on that can prevent the blindness that we used to see from glaucoma. Macular degeneration is probably still one of the tough one that we don't have full, complete treatment for. We can treat certain forms of it, but not all of it. But still, the sooner we catch macular degeneration, the easier it is for us to treat it. So 1/3 of new blindness is probably avoidable. So we'll talk about each process individually. The first one is age-related macular degeneration. So this is considered the most common cause of vision loss in the elderly. And like I said, this is not a normal aging process of the eye. This is an actual disease that not everybody will get, but some people will. So in this disease, you lose the center part of your vision. The periphery remains intact. Some of the risk factors are Caucasian ethnicity, advanced age, fair skin. If you have a family history, a lot of patients will come and tell me they did the 23andMe genetic testing and it says positive for macular degeneration. So it does run in the family, but just because you have it in the family doesn't mean that you'll necessarily get it. Smoking is one of the big risk factors. If you're a previous smoker, later on, you could develop this disease process. So this is a picture of the back of the eye, and this is something that we see in macular degeneration. Normally, when we look in the back of the eye, we don't see all these little yellow deposits. So these deposits are what we call drusen, and that is typical of macular degeneration. And this area right here is what we call the macula. So when we see these deposits in this area, it's pretty specific for macular degeneration. So we can see these findings, and people might have bare to minimal symptoms at this point. But macular degeneration is a progressive disease. So the first form, what we call early age macular degeneration, or the dry kind, is what I told you. We see all these little yellow deposits, but this can change to what we call the wet macular degeneration, or neovascular AMD. This is when we see new blood vessels grow underneath the retina, but those blood vessels are not good. They break and they bleed. And then they can leave this scar at the end, which causes blindness. So unfortunately, we don't have treatment for this early kind. We tell people to maybe take vitamins, don't smoke, obviously, eat green leafy vegetables. And there's lots of research being done right now to find a treatment for this kind. So these deposits will remain forever, but we don't want it to change to this wet kind. If it changes to the wet kind, that's the kind we do have treatment for. It would be injections into the eye, which again is not a cure, but the point is to slow down progression of this macular degeneration. So patients with macular degeneration, I usually give this little grid, and they do it at home. They put it on the back of the door or the refrigerator, and they cover one eye and they look straight at that dot. And you will make sure all the lines are present and all the lines are straight. This is a sensitive test for detecting if anything is going on in the macula itself. So this is how it would look if there was some problem. Someone would say this middle area is distorted, and that's very specific for something going on in the macula. I like to put this picture in because it can show you in general how a patient with macular degeneration might see things. So this is a normal picture, and people with macular degeneration would see the picture like this. So it's loss of the center part of the vision, but the periphery around it is usually intact. So macular degeneration symptoms. Early on, some people might say difficulty reading, just general things. It's more blurry when they're driving. Straight lines appear crooked, but I see a lot of patients where early on they have zero symptoms, and all we see are those little yellow deposits. So advanced, then we get this central blind spot, and the peripheral vision remains intact. So this is a picture we do in our clinic. It's a high definition image of the retina in the back of your eye. And this area is the retina. We can see all the layers of the retina. And this area right here is irregular. This is basically fluid underneath the retina. And that's from those irregular blood vessels that have grown back here and leaked out fluid. So the treatment, as I mentioned, obviously follow up with your ophthalmologist. We usually see people every 6 months or so. Stop smoking. I would control any systemic disease processes that would help, such as blood pressure, cholesterol. Diabetes, they say, doesn't affect the macular degeneration as much, but you should have a diet high in fruits and vegetables, specifically green leafy vegetables like spinach, kale, broccoli. Specific antioxidants have researched to be known to be helpful, such as zinc, vitamin C, and E. They even sell these macular degeneration specific vitamins over the counter, and they're called AREDs, and they have all these specific components formulated into one vitamin, which helps. So lutein, that's also another vitamin that's in the AREDs. And so I talked about the injections that we do for the wet macular degeneration. So the next process we can talk about is glaucoma. So glaucoma, like macular degeneration, but I would say is more tricky because it's often called the thief in the night. So patients usually have zero symptoms. Even in the early to moderate stages, they can have no symptoms. So this is what's scary. In glaucoma, you get a subtle loss of the vision in the periphery and the center part remains intact. So glaucoma is very important to see your ophthalmologist routinely because we do specific tests that we can detect and treat much earlier on. So this is an example of a picture a patient with glaucoma would see. The center vision is spared, but all here in the periphery becomes very blurry, and that's what's affected in the disease. Sorry, I'm having a problem with my slide. Okay, so glaucoma, second most common cause of vision loss after macular degeneration. And in converse to macular degeneration, glaucoma affects more commonly African Americans, and usually in the older population, greater than 70. But definitely this day and age, we have so much early detection and treatment. So it is very more rare for us to see patients who are blind from glaucoma. So risk factors for glaucoma, genetics still plays key here. African-American race, if you have high eye pressure, that can put you at a risk of glaucoma, but just because you have high eye pressure, that doesn't necessarily mean you will develop it. There's different types of glaucoma. There's actually low pressure glaucoma, there's normal pressure glaucoma. So a lot of patients think that it's just related to the eye pressure. It is, but there's different types of glaucoma. So hypertension and diabetes is also a risk factor. So the cause of glaucoma, as I was mentioning, it is a pressure thing, but in general, a fluid is created in the eye, and that fluid is supposed to drain out of the eye. In the most common cause of glaucoma, when the pressure is high, this fluid builds up inside the eye and the drainage system is blocked and the fluid builds up and the pressure gets high and it starts to damage the nerve, which is in the back of the eye. So it's similar to this analogy of a cable carrying vision signals to the brain, and the coffee grounds, the pressure in the eye, blocks the sink drain. So this is a picture of the nerve, the optic nerve in the back of the eye. So on the right, we have a normal looking nerve, and you can see this whole thing is called the disc, and this little part we call the cup, the white part. So you can see this cup is pretty small, and you compare it to the left side, the cup is a lot bigger. So in glaucoma, we see this enlargement of the white part of the nerve, because as you lose the nerve fibers, the cup becomes very big. And so we call that cupping. That's just what we see on exam. So like I said, there's many different types of glaucoma. The most common one is open angle glaucoma. There's also angle closure glaucoma. There's glaucoma associated with medication, different disease processes. But I think I'm gonna, in general, talk about the more common one, which is open angle. So in the eye, as I mentioned, there is a fluid that is produced right here by some little microscopic cells. That fluid bathes this area of the eye, and it goes in the back into this area of the eye. And when it drains out, it goes through these little purple meshwork channels. And so in primary open glaucoma, this meshwork where it's supposed to drain out is open. That's why we call it open angle glaucoma, but still the person has high eye pressure or there's damage done to the nerve, which we could see the nerve will get large. So we have special tests we do in clinic. This is actually probably the most sensitive one. It's visual field test. And I tell people it's kind of like taking a video game or doing a video game. You sit in this chair, and this is the patient right here. And you look at one dot that is in the center of your vision, and you just stare at that dot, and you will see different lights flashing in your periphery. And you have to push the button every time that you think you see a light. It is a very subjective test, meaning the first time someone takes it, sometimes they do a horrible job because they look other places, they push the button too much, and it's not a reliable test. So over time, after 2-3 times of taking this test, it becomes more reliable and we can get an accurate conclusion from this test. So with treatment for glaucoma, what is our goal? Our goal is obviously to stop people from losing more vision, to prevent further damage to that optic nerve where I showed you the picture where the cup was getting very big. That will stop getting bigger on exam if we treat it. So we use medications to lower the intraocular pressure. And then usually in clinic, when I see patients with glaucoma, I will do that field test about every 6 months or so. So surgical treatment of glaucoma, we have a lot of advances right now currently in this field. So there's laser surgery, there's surgery where we actually put a tube, a drainage tube into the eye that helps drain the fluid another way. There's also procedures where in the operating room, we do certain things to the drainage canal. We can open it up, we can put devices directly in the drainage canal. So it's a very evolving field, and this is the time and age where we have so much technology. Even as I speak right now, there's probably devices that are being out on the market like right now. So the last topic I was going to cover is cataract. And I personally think cataract is the most, they're all important, but cataract is important because everybody is going to get it. It's not something that you might get, everyone's going to get it. So what is cataract? So everybody has a lens inside your eye, and that lens is supposed to be crystal clear for us to see out of. And as we get older, I would say older than 60 years old, that lens starts to turn a little bit more yellowish brown. And then at that point, people will say the colors become a little bit more muted. You might need more light to see things. The lens also gets hard. So normally the lens will move for us to focus up close, but as the cataract develops, the lens doesn't move as much, and that's why people need reading glasses. So that's what we call the loss of accommodation or focusing up close, and that term is called presbyopia. So cataract, like that picture that I shared before, is just a general clouding of everything. Everything won't be as bright. Everything won't be as sharp. It's not just specifically in the center or in the periphery. And over 2 million cataract surgeries are performed in the US. And this is the third most common cause of blindness. So this is a picture of the eye itself. This colored part of the eye is in the front of the eye, and this is towards the back of the eye. This is that optic nerve that we looked at before. And the lens is this, which sits right behind the colored part of the eye. So this is just some picture of, I thought it would be helpful to show you challenges that people face, even just when driving with the cataract. So you see this reduced contrast sensitivity. Things are not as bright and as sharp. It looks kind of dull or blunted out. And on the bottom, this is probably the most common thing people tell me is when they drive at night, they're very bothered by the glare and the halos coming from the cars directing towards them. So a lot of people will give up nighttime driving. So that's actually a very common symptom. So we talked about what is the cataract. It's an actual yellowing of the lens that we have inside our eye. In 90% of causes, this is normal. Like I said, it's a normal part of aging. But some things can make a cataract come on sooner, such as people that have had radiation treatment for different cancers, diabetes. If your diabetes is very uncontrolled, it can cause the cataract to come on a lot faster. Trauma, obviously, if you're hit in the eye, that can definitely cause a cataract. And certain medications, specifically steroids, we see cataracts a lot more sooner. So cataract symptoms, the glare at night. In general, people will say you need more light to see, even when reading, even if you're in a movie theater. It's just would be very difficult to see in general. So cataracts grow very slowly. It's not going to be a couple months. I see a patient and a couple months later, it's going to be pretty bad. I tell people progressively over the next 6 months to 1 year, every year it will get a little worse. But I would say on average, 70 years old is the time when most of our patients have cataract surgery or they're getting close to needing cataract surgery. So cataract treatment, the nice thing about cataract treatment is I always tell people it's voluntary. It's not like heart surgery or something that's going to be life-threatening, but it definitely is vision-threatening. So there will come a point where I tell people the glasses won't help anymore and I can't help you anymore with the vision until we go into the eye and remove that brown lens. So most people will come to me and tell me they're ready for cataract surgery. Unless the cataract is causing a medical problem, I tell patients they're more than happy to wait if they're okay with this vision. But as the vision continues to get worse, people will notice driving will get worse. If they go to renew their license, the DMV won't give them a new license unless their vision is treated. So those are basic things. Daily activities that might be affected include reading, knitting, people's hobbies like golfing. And you might see some ads on TV. I think I saw one like a couple weeks ago about this new eye drop that slows down the progression of cataract. So there is no known treatment, medical treatment to this day that can cure the cataract. It might slow it down a little bit, but it will never treat it. Unless we actually go in and remove that cataract, it will never be cured. So there's been a lot of advances in ophthalmology, specifically cataract surgery. And if we look at 1980s versus 2009, and this is even probably more right now in 2023, but then in 1980, you would have to stay in the hospital. It was an inpatient procedure. Now it's outpatient. We tell people within 4 hours, you should be in and out of the outpatient surgery center. Then it took maybe 2 months before useful vision was restored because there was a lot of swelling, a longer recovery time. People wouldn't be able to go to work as quickly. Now we tell people the next day when we remove your eye patch, you should be able to see right away. And before, they didn't have lenses that we could replace inside the eye. So people would have to wear very thick glasses or very rigid, hard contact lenses or other things that would be very uncomfortable. These days, the goal is for someone to not wear glasses afterwards. That might be just for the distance, and for reading, you still might need glasses. But we have intraocular lenses, and this day and age, we have lenses that correct for all sorts of distances. So some people want to be corrected for up close. Some people, they want to see far away. So we have many, many different options now. And some people, a lot of people actually ask me, how do you actually go into the eye to remove the cataract? Do you have to go into the eye, or you can do it some other way? So this is a little short snip of how we actually do cataract surgery. So we use this technique called phacoemulsification. I tell people it's kind of like a small device that vacuum cleans out that lens. So this is the device here. The lens actually sits in a little bag. So we have to first make a hole into that bag here, and then we vacuum clean out that lens. The whole process of the cataract surgery, I would say, takes like 20 minutes. It's a very quick thing. There is no blood loss. It's very clean. Most patients, we don't even give them general anesthesia. So they're awake. We give them local anesthesia to make you a little sleepy. Sometimes you can hear us talking in the background. But because it's such a quick procedure, it's nice because we don't have to put you under general anesthesia for more risk. So 90% of patients achieve a vision 20/40 or better. Complications are very, very rare. The infection rate has decreased so much compared to even 5-10 years ago. We're able to give antibiotics during the surgery, and the ones that we use before and after are really good at preventing any infection rate. Sometimes people get a spike in your eye pressure, but usually that's treatable with drops, and that's not a permanent thing. Retinal tears or detachments can happen with cataract surgery. Even though we're operating in the front of the eye, sometimes we can get complications which transmit back to the back of the eye. That's still very low, 0.01 to 0.02%. The most common complication, and I don't actually like to even call this a complication, more like a side effect. I tell people like 90% of patients will get this, and it is posterior capsular opacification. I don't think maybe 15%, 15% is accurate maybe in terms of getting it within the first month. But honestly, I would say this posterior capsular opacification is more like 85-90% of patients will get it. And what it is it's because after cataract surgery, we insert an artificial lens into the eye. That lens is made out of another material. which the body doesn't recognize. It's like silicone or acrylic. And so your body doesn't try to reject it, but these cells, they start to grow on this artificial lens in your eye. It's just trying to figure out, what is this fake thing? And that's what we call a posterior capsular opacification. The treatment for this is very easy. It takes like 5 minutes. We do it in clinic. It's a little laser, and the patient sits in the laser machine, and we laser real quick for 5 minutes. We clean off that dirty lens, and that will never grow back again. So in general, Gavin Herbert Eye Institute, we have about full-time faculty of about 15 to maybe 20 clinical ophthalmologists. We just added a couple new people. So we have all these subspecialists available, and we just added an ocular oncologist who is actually going to be the only oncologist specializing in ophthalmology in the Orange County area. So you can get things such as melanomas just localized in the eye, and other eye disease, other eye cancers. So that's very important. We also hired another glaucoma specialist, and we're going to hire another cornea specialist. So it's a lot of good faculty that have joined our clinic, and it's nice because patient care is very focused, and we can send someone to one of my subspecialists in the same clinic, which is very convenient and easy for the patient as well. So here at Gavin Herbert Eye Institute, obviously I work here, and I'm not biased, but I'm sending a lot of my own family members here because I really believe it has the most experienced team of doctors. We get access to the newest treatments available. There's a lot of ongoing new research that has been done. And we get the access to right treatment at the right time. If our clinic is closed, I always tell people, one of us ophthalmologists is always on call at the UCI main hospital in Orange. And so that is open 24/7. So if you have any eye emergency, you're always welcome to go there, and one of us is always on call. So I hope this lecture was useful to you. If there's a lot of new patients, I'd be more than happy to see you. Come to our clinic and meet all of us. We'd be more than happy to help you. So some take-home points. This day and age, we have a lot of new treatment options for macular degeneration. I think I stressed the importance of early detection for glaucoma and how that can save vision. This day and age, if you see an ophthalmologist, it definitely should be caught. And actually, I haven't seen someone going blind from glaucoma in a very long time, maybe more than like 10 years. They do exist, but by that point, I don't think they would come see me because I'm the general ophthalmologist that would detect things. Advances in cataract surgery, there's lots of new things, including this lifestyle lenses that I talked about that correct for all different types of distances. So we have premium lenses, and those lenses correct for all distances. And so patients don't want to wear glasses, so they pay for these special premium lenses. We even have lenses that can correct for patients' astigmatism. We have special lenses that help for people that have a LASIK. So lots of different technology. So thank you for joining with this lecture. This is our line for making appointments. But at this point, I guess I'd say I'm open to questions. If anyone has a question or comment, feel free to ask.
Thank you so much, Dr. Rao. I think Dr. Liebler said it best, that you are a great credit to Gavin Herbert.
No, it's such a pleasure to see these patients, and I hope this lecture was useful, and I hope to meet you all soon.
Thank you, Dr. Rao.
Take care.